Hello, Kidney Warriors. James here from Dadvice TV, your online kidney health coach, and this is the latest episode of Dadvice TV Live. For those of you joining us for the first time, welcome. Great to have you here. For everyone else, always fantastic to have you with us. Now, tonight, we've got your guys' favorite nephrologist here. He's going to give us some of the latest information about eGFRs, what it means. We're going to talk about CKD stage 3, which covers the majority of people out there. And what's the latest news? What do the numbers and the things really mean? All right, so let's go ahead. And before I welcome him on, for those of you that don't know, our co-host, his name is Dr. Steven Rosansky, and he is the author of my favorite kidney book, and he tells me he's working on a new book. Can't wait to hear what that one has in it and get a copy of it once he's got it done reading or written. But the book that he's written is called Learn the Facts About Kidney Disease. Now, when I was diagnosed with kidney disease, I wish my doctor would have said, hey, I know it sounds scary. I know you've got a lot of worry, but here, read this book. This is going to tell you what you need to focus on, what's important. It's going to talk about diet. You're going to feel much better. It's going to take a lot of those worries off your shoulders, out of your mind, so you can focus on what you need to do to manage your kidney disease. But let me go ahead. Oh, and before that, look at that. We already got a good evening from Springfield, Ohio. Hey, I know Springfield, Ohio. I was born in Washington Courthouse, Ohio, not too far from Springfield, Ohio. But let's go ahead and let's welcome my co-host, Dr. Steven Rosansky. Hey, Doc, how you doing?
Doing great, James. Good to see you as always. In this nice cold weather, we're gonna have 20s and 30s in South Carolina. I can only imagine what you're gonna have.
We have a high of 2 coming next week on one of the days, and I think the day after that it's a high of 6. It is currently, well, it did warm up. It's 29 right now here.
A heat wave. Yeah, it's
Yeah.
pretty crazy. Yeah, this is probably gonna be the coldest week of the year. And yeah, we're gonna go visit my youngest kid who is out in the LA region. Luckily, she's safe, but that's been a crazy, crazy situation.
Oh yeah,
Really.
my heart goes out to everyone out there.
Yeah, yeah, it's very, very crazy, very sad. Anyway, James, you want me to introduce my background and myself in case you happen
Yep,
to
that way
be?
people know why the things that come from you are important and that we can trust them and that this is the information we need to follow because the internet is full of so much what we call woo-woo, that fake stuff.
Yeah, we'll get a little bit to the woo-woo discussion towards the end of today's talk. I am a kidney specialist. I've taken care of kidney patients, internal medicine patients for over 40 years. I retired, but I still see patients in the free clinic. I see some kidney patients. I not only have taken care of lots of patients, but I've done lots of research. I've done research on some of the drugs that you may be using. And I also did a lot of original research. And some of my original research has to do with things that affect the rate of decline of kidney function, as well as when it makes sense to start dialysis, which is one of the prime reasons why I wrote my book, because far too many folks were starting dialysis way, way, way too early at high levels of kidney function when it was unnecessary. And my research, which was called the #1 game changer when it came out in nephrology for the year, I think it was 2011, if I'm not mistaken, basically showed that starting at a higher level of kidney function is harmful. You will not live as long potentially in comparison to waiting till your kidney function gets to a lower level. And I've done a good bit of research, and I've been involved with randomized controlled trials. And when James says woo-woo, I can't, we'll talk a little bit about this later, but let me just mention at the get-go. Most of you have no idea what a research study is about because you haven't done any on your own. Research is, randomized controlled trials are extremely hard to do, complicated, cost a lot of money, take a lot of time. And if you want to get something publish in research, you have to have people like myself, experts, review it, make sure that it's good stuff. I am kind of more than a little bit disturbed that one of the other books out there for you folks, kidney patients, is writing a book on his own research, which I basically call anecdotal, and it's kind of nonsense. So please don't fall for the anecdotes, don't fall for people that are trying to tell you things without being qualified, and stick to what the kidney docs around the world recommend, which is what I'm going to talk about tonight. So we're
Perfect.
going to talk about okay. So we'll hammer this a little more in a few minutes. So I'm going to surprise you tonight, James, because there's some stuff that's going to be a little bit confusing. So we know that those of you who have watched James' show, heard me talk about CKD3, know that for a while there was a lot of worry about GFRs in the upper range. Let's call it the upper range, your eGFR, your estimated kidney function, estimated glomerular filtration rate. I try to explain what that is in my book. It's a mouthful, but hopefully you'll understand it if you read it. And so what's happened is that because higher levels of GFR, let's say above 60, those estimates are unreliable, some labs have decided to just say over 60 without giving you a number. And James knows the commonest way to get your CKD cured is what, James?
A second test.
Yay! And because of that, how do you define CKD in today's world by the International Kidney Organization of doctors like myself, giving their opinions? How did they define it?
2 tests 3 months apart, both showing a low estimated kidney function.
Below 60. Below
Yep.
60. Okay. Okay. Now, here's the news. A little bit upsetting news to some people. Can you have CKD if your GFR is over 60?
Yeah, I would say if you have high
Okay.
protein in your urine or something like that.
Aside from just high protein in the urine.
I don't know.
Okay. What happens to your GFR with age? Basically, from the age of 2 to the age of 40, it's about the same. Starting at age 40, it starts declining, okay? And we've gone over this many times. So that those of you who are so-called stage 3A, which is what, James? What eGFR?
3A would be 45 to 60.
Perfecto. Okay. So if you are over 70, that's a normal eGFR if you don't have significant protein. And why is that? Because the research shows for folks that are in this age group, let's say 70-ish age group, with that eGFR, you're not at a higher risk of the thing that James loves to talk about.
Hardening of the arteries. It's heart disease.
Yeah. Okay, right. Heart attacks, strokes, and the bad stuff like that. And which is why we check eGFR, because that's a risk factor, like smoking, like high blood pressure, like diabetes. The other thing is, you're at a higher risk of kidney failure at a certain level of eGFR. So, and for you folks that are in the 70 range, like in Australia, they don't consider you to have CKD if you've got 3A and you have normal protein, not CKD. But here's the news. When you thought you had it all figured out. Okay, what's the normal eGFR for a young adult? And I don't know how many young adults listen to your show. Take a guess.
Is it above
Normal.
90?
105.
105. Well, that is above 90.
Yeah. So basically, if you are 40 to 60, even in eGFR, these are some younger folks, even in eGFR 70 to 80 may not be normal. And it is possible that you may have the higher risk if you are in the younger age group of progression and of the hardening of the arteries risk. So we haven't done this yet. The international organization, kidney organization called KDIGO, Kidney Disease International Group of Kidney Doctors. The latest publication has not yet said that we want to do what, James, which we should do. We should have
Oops.
what?
So sorry, I was reading all the questions and marking them for later. There's a lot of great questions coming in.
Okay.
Keep the
All right.
questions coming in, everybody.
Yeah. Well, we'll try to move a little quicker so we can get to them. But age thresholds. A lot of people have been banging the table to say, let's have age thresholds. Okay. So if you're younger than 40, right? You probably have an abnormal kidney function if your GFR is less than 75.
Mm-hmm.
Okay, and some labs are not reporting it, so we got a problem potentially.
Yeah, because
Okay?
they're just saying above 60 and
Yeah,
saying it's
isn't that interesting?
okay.
And so if you're 40 to 60, that's fine. Less than 60, if you're in the 40 to 60 range, which is probably a lot of your viewers, I would guess. And if you're less than 60, that's considered CKD. And if you're older than, let's say, 65, if you're less than 45, you will say you've got CKD. Now, here's some more kind of very confusing news. Some people, especially older folks that are very frail, may have an eGFR over 100. Crazy, right?
Mm-hmm.
Why could that be? Now, this is going to really see if you understand this stuff.
If they're
How?
fragile,
Yeah.
well,
What
it's
is the
not because of
eGFR depend? What is eGFR depending on?
creatinine, which is
And
muscle.
what is? Yes.
Yeah.
If you've got someone that's just wasted all their muscle away, that's going to raise their estimate because that
Aha.
creatinine is in the denominator of the equation that determines your eGFR. So anyway, here's some more news. Okay, there's two lab tests that are used. One is creatinine, which we talk about all the time. Creatinine is just a marker, and the eGFR is mostly used in most of the labs is creatinine based. What's the other way to measure? What's the other lab test that can be used? Another marker, just like creatinine, to measure GFR.
Was that the one that's it's like Siestin C or something like that?
Cystatin C.
Cystatin
Cystatin C.
C. But that
Cystatin
one's
C.
more
Okay?
expensive.
Exactly. Exactly. Okay. But it's probably better for people who lose a lot of muscle.
Mm-hmm.
So, if you want the most accurate way, it's going to be expensive. Get the average of the one that's estimated with creatinine, and get the average of the one that's of the two of them, and that's estimated with cystatin. If there's confusion about you're unusual in terms of your muscle mass or whether you have liver disease, and you change in your body composition, you might want to ask your doctor, hey doc, why don't I do a eGFR using cystatin C and creatinine? Okay. And so, by the way, as I said, we are not age adjusting yet, but the International Kidney Organization has produced all kinds of charts, and they don't just put on your chart your estimated GFR. They also put on what, James? To stage you, to say how serious is your kidney problem.
Yeah, it's going to be your stage 1, 2, 3, 4,
Your
5.
eGFR determines that, and what's the other thing that helps determine it? Not just the eGFR. We talk about it all the time.
I am not certain what you're looking for.
The urine protein.
Oh yes, urine protein, because that's really important. Yes.
Yeah, it's critical. So the new stages to tell you what risk you're at for getting the hardening of the arteries or going on to develop kidney failure combines your eGFR and your level of protein in the urine. And as it turns out, there's been all this worry about an eGFR that probably doesn't mean anything for people in their 70s and 80s when it's like a 50 or so,
Mm-hmm.
And people worry all the time, oh, am I going to go on dialysis? No, you don't really have to worry, especially no protein in the urine. that protein is the more important risk factor for most people in determining whether you're going to progress to need dialysis or transplant, and whether you're going to get one of these bad events from hardening of the arteries, whether it be heart attacks, strokes, or heart failure. And there's another thing that the international organization is pushing, and it's in my book. It's a little bit wonky. It's called the kidney failure risk equation, or KFRE, okay? So what that is in my book, and you'll find all this in my book, and you can go over this with your kidney doc. And so they're asking doctors to give you the prediction of what's your likelihood. Well, everybody wants to know that you're going to need a dialysis or transplant, let's say in the next 5 years. And what's the most important factor determining that? We've talked, you know that, James, right?
Yeah, I'm so sorry, Doc. I am reading
You're looking at
comments.
everybody's question. Pay attention, because I'm going to continue to quiz you. We're going to get to the questions in a minute. And what is the most important factor determining if you're going to be one of these unfortunate people that are going to be faced with dialysis in the next 5 years?
Protein in your urine.
Exactly, right? So that equation combines factors, your age, sex, race, and the protein in the urine, measured by, as we've talked about many times, a urine sample, which measures the urine albumin, and it measures urine creatinine. You can get a dipstick to do it, and we've talked about dipsticks. You can buy them on Amazon. You can check your urine protein, but your doctor, your kidney doctor, your GP, should be getting a urine for albumin and creatinine. That'll tell you how much protein you really got in the urine. So why are we talking about this? Because we want to know if you're at risk for getting one of those hardening of the artery problems or progressing. So here's something that we've talked about a lot. What you really want to know is, what is the likely rate that your kidney function may change? In a lot of people, especially older folks, it may not change at all over 10 years. And I've got several papers that discuss that. I got published papers that talk about older folks, even with CKD4, like James, who's a CKD. And I just scolded James because he didn't get his labs followed for 2 years, James.
Almost 2 years. I haven't had new labs.
Bad boy. I mean, if you've got CKD4,
I have the order now to go get them. I did show up at a lab and said, "Hey, I want to know what my eGFR is." I made an appointment and I showed up, and then they told me, "Oh, you need a thing from your doctor. You just can't show up and get them."
Anyway, if you've got certainly CKD4, please, at least once a year, get your GFR checked. But lots of people with CKD4, especially older folks, they can have it for years, 10 years or more. And I've got several reports on that. So, and that's because older folks, if they're going to lose function, they may lose 1 to 2 units a year. As opposed to a younger person who's got heavy protein, they can lose more than 5 units per year. So you can lose kidney function really fast. And we've talked about this several times on your show. What is serious proteinuria? James, you have any idea?
It is 2+. Well, it depends on the measurement, the country, but it's 2+, correct? On
2+ for sure. I would say even 1+ or more consistently. And that's just a rough idea. It's just a screening test. Get your albumin to creatinine ratio. I would say over 200 in the US and over 20 in the rest of the world, because they use different units. That's significant protein. And we'll always say this in every show. Remember, for most CKD patients, you should be on a what or a what?
an ACE or an ARB.
And you know you're on an ACE or an ARB, James, by what letters?
Because they either end in pril or tan.
For an ACE, ACEs end in pril, like haptopril, and tan, like losartan. That's an ARB. Those drugs, they not only can theoretically slow your kidney function decline, they can decrease the protein in the urine, and they can lower. They're great blood pressure drugs. Most people with CKD have high blood pressure, and they also lower your risk of these bad events from hardening of the artery. So, good drug to be on.
I also love that they're
And
very common and extremely
cheap,
affordable.
cheap, 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 cheap. The drugs that are not so cheap, which I highly recommend if you're diabetic and you've got CKD, are the SGLT2s, the gliflozins, the canagliflozins, the empagliflozins, the DAPA. Anyway, the brand names, I don't know how to pronounce it, James. FARXIGA. How do you pronounce it?
Farxiga,
Are
because they
you
run
sure?
commercials on TV. And Doc, they just ran a commercial this month in
Yeah.
January,
Yeah.
and the side effects that it
Yeah.
mentioned were not good. I would not want to take that one.
Well, I would have to. So here's something that I'll teach you, James, and teach your viewers. Do not be scared by these side effects because the side effects are minimal for the drugs that I'm recommending, whether it's ACEs, ARBs, or the SGLT2s. Why do they have a long list of potential side effects? I've done these drug studies. If you try to get a drug approved by the FDA, you're in one of my research studies, James, and you
Mm-hmm.
say, "Hey, doc, I'm having this problem with some weird thing in my whatever," and I go, "Well, I've got to decide as the researcher, is this drug related?" And many times you can't know for sure. So you've got thousands of patients in the study. They can have all kinds of things that may have no relation to the drug itself, but the researchers have to report it, and it goes into those
Mm.
long lists of potential scary things. Okay, so these drugs are very safe. As a matter of fact, for diabetics, I would highly recommend if you're diabetic with CKD, get on an SGLT2 because it can not only slow decline of your kidney function, but help you live longer. These are
Yeah.
some of the longevity drugs. And by the way, the book I'm working on is How to Live Longer, Healthier Lives, a longevity book. And these drugs are game changers. The SGLT2 drugs are game changers for longevity. So they're expensive, but if you're diabetic,
Mhm.
it may be covered by insurance. The GLP-1s, they are another drug that may slow the decline of kidney function and especially if you're diabetic with a good bit of protein, at least consider it. Very expensive, and these are the weight loss drugs, the Ozempic.
Yep.
Okay, these are the glutides, the semi-glutide like Ozempic. Um, if you're diabetic with proteinuria and you can get on one of these drugs, especially if you're trying to lose weight too, I would say it's reasonable. Diabetic, protein in the urine, CKD, if you can get one of those, I would get it. The third type of drug, there's a buddy of mine that did the research on it, and I love the guy. And it's called finerenone, and it's the same kind of drug that James takes for pennies, called spironolactone, and that drug is cheap as all get out. Uh, there's a real expensive version that they researched on called Corendia, and I wouldn't waste my money. It's another drug that can theoretically benefit you if you've got high protein in the urine and you're diabetic and you got CKD. But I would take the cheap ones like there's another one, by the way, besides spironolactone. It's called eplerenone. So I would not personally be pushing that finerenone unless you can get it cheap. And you've got heavy protein and you on these other drugs, it would be third in the list. What about those of you who had some urine tests and you got low levels of protein in the urine? Not the 200 in the US, but let's say 20, or not 20 outside the US, but let's say 2, real small.
Hmm.
These levels are not reliable, they vary a lot, and it's worth following. And they can vary by having infections, by the medicines you take. So I wouldn't get real excited with very low levels. Now, what you should do and what you should not do if you've got CKD3. And we just discussed this, and I'm surprised at James. When should you expect to have symptoms, James? Although you may actually fit in the category. At what level? CKD3?
No, there it would be extremely rare to have any symptom
Exactly.
at stage
Exactly.
three.
Exactly. And there's
Stage
so many.
4, they start to
Yeah.
show up. For me, I just thought it was, I'm getting a little older.
Yeah. Stage 4, especially if you get anemic, you get a low blood count, you can certainly start getting symptoms, no question about it. But all these woo-woos and all these things, which we're going to list in a minute, they say, oh, you got all these symptoms from your stage 3. That is total BS. Okay, don't believe that BS. Forget about trying to lower your creatinine. Why, James?
Because creatinine is not the problem, it's just a marker. And it's funny, my doctor explained it best to me, and this is a long time ago. Like, you know what, if we amputate your legs, your creatinine will go down, but your kidneys aren't going to get better, and now I got to use a more expensive test to estimate your function. I was like, okay, I understand now.
Yeah, yeah. It's determined. It's relative to the amount of muscle in your body. Your muscle gets metabolized. The creatinine gets metabolized in your muscle. The same amount is excreted every day by your kidneys, and that's why it's used as a marker. And so many people say you've got CKD and I can reverse it. These are BS because there's no reversing. You may have had something called what, James?
An
Which is all,
AKI.
yeah, and that's has nothing to do with whatever they're suggesting. You can have an AKI, which we're going to get to in a minute, that does reverse, but they're saying, oh, you've got an eGFR of 45, and I can get you to 50. I mean, nonsense. And we've got testimonials. Don't fall for any of that nonsense. Don't fall for the anecdotal research that I talked to you about at the beginning of the show. Stay with the real research you hear from doctors or from anybody on James' show. James, I got to give James a lot of credit. He could have been pushing the woo-woo and making bucket loads of money, but he is a honest broker and he is giving you the real stuff, and he's not
This
going to
is
put that on the
because
show.
this is a free education for me. Healthcare in our country is so expensive. I get you, I get others, dietitians on. I'm getting free advice.
But you're a good guy, James. There's no getting around it. Anyway, and people say it's going to get progressively worse. Nonsense. As I've told you, you got a GFR of 40 or 50 or 45 or 55. Don't worry that next year you're going to be on dialysis. For lots of you, especially older folks, minimal protein, you can be stable for years. And
Or
there's
even
lots of,
decades at that point.
yeah, yeah. There's people pushing naturopathic stuff, herbal stuff, and probiotics. No proof, folks. No proof. I would not waste your money, especially when there are things that work, the game changer drugs we just reviewed, whether it's the ACEs or the ARBs or the SGLT2s or even the GLP-1s. That's what makes sense if you need it. And don't fall for any of these ridiculous diets or the kidney coach giving you home remedies. Please don't fall for the kidney repair pill. James knows those.
What
Or
about
the
the kidney
natural
flushes?
the
The kidney
kidney
flushes,
flushes.
the restores. There's so many
Um,
of them.
so there's no need for a natural diuretic pill. If you happen to have fluid overload, too much salt and water in your body, there are wonderful diuretics. They're safe, especially you use it under a doctor's control. They're safe. Doctors know how to use them. That's what you should use, real diuretics. What about drinking a lot of water like James is drinking? Do you need to flush your kidneys out? Do you need to drink a lot of water?
No, you just need to drink the amount that you need.
When you're thirsty,
Yeah.
the amount of water you should drink, you should gauge by your thirst. It's an amazing mechanism. And I've done a lot of research into that mechanism of the thirst and how your kidneys control your water balance. It's very finely tuned. Your kidneys know what they're doing. There are a couple of situations where you do want to drink a lot of water. That's if you have what, James?
Let's see, window kidney stones.
Exactly. Kidney stones. First thing you want to do is make sure you stay well hydrated. If you're taking things that could possibly harm your kidney, taking drugs that could possibly harm your kidneys, you want to stay hydrated, okay? So those would be the situations. And what about the diet? James has a great dietitian on the show. Jen knows her stuff. I think Jen and I are on the same page. Plant-based diet. I call in my book, you'll read it, I call it my smart diet for CKD. It just emphasizes the smart things about plant-based diet, having a lot of fiber in your diet, because those are the things that are going to give you the best health. And most of you want to decrease your risk of having problems from hardening of the arteries. And a plant-based diet is the best, even certainly for CKD3. CKD4, probably also fine. Maybe even CKD5. What do you got to do if you want to continue on your plant-based diet? Very simple, James. What?
Wait, repeat the question.
If you are in CKD 4 and 5, and you say, well, I'm on a plant-based diet, it's good for my health, it's good for my longevity, should I continue it? What do you need to do in order to continue it safely?
So I'm going to say definitely work with a dietitian who can help you so your blood sugar is not going to spike one way or the other.
And more importantly, what do plants have? What electrolyte?
Is it? Well, it's not potassium.
Yes, of course it's
It is
potassium.
Okay.
Potassium is in plants. Plants and potassium go together, the two P's, right? And potentially, if you're eating a lot of plant-based meals, that could affect your potassium. But as long as your doctor checks your potassium, you'll be okay. Hey, if it stays in a good range, stay on the plant-based diet. My book, we talk about diet. We say no need for severe restrictions of protein for sure, a moderate restriction, instead of eating 120 grams, maybe 80 to 100 gram protein diet. And less sodium is probably good. If you can stay away from high sodium, probably good for your blood pressure for sure, and probably good for your heart.
That's always my number one concern. Is I look at sodium. I don't watch the calories. I don't watch the sugar very well, but I watch my sodium like a hawk. I make sure I'm not going too high, and I can tell if I went out to work or something and we had dinner out, I can tell all night long because I'm up peeing all throughout the night and I'm like so thirsty and I know that was too much sodium.
And James is one of these folks that has a difficult blood pressure problem. And for sure, a lot of salt, a lot of sodium will jack up your blood pressure. So yeah, if you can, restrict your sodium. And most of the sodium is in your foods, not in the salt sugar. And most of you folks that go out to eat, most of the places you go are going to be high sodium, especially fast food. So again, we're talking about what to do about CKD3, plant-based diet, a wise diet, moderate protein restriction, reduce the salt. Of course, stop smoking. The most important thing you can do, like we said, having a abnormal eGFR, having CKD, a risk factor for heart disease and dying of a stroke or heart attack. Cigarettes are much bigger risk factor for deaths from heart disease, death from cancers of the lung, etc. You all know that. Get rid of the cigarettes. And we just talked about this. If you're with James, if you're diabetic and you have kidney disease, especially if you're an older person, don't mess around trying to get to an A1C of 6.5. 7 to 8 is safe because low sugar kills. And low sugar is common with older folks with kidney disease, so be careful. We're going to spend a few minutes now on your favorite topic, James, AKI, right?
Yep. And yes, go ahead. And I want to make sure that people understand out there, you can have CKD with an AKI. And then once the AKI passes, you get better. Your eGFR went up, but that doesn't mean you cured your kidney disease. You just took care of one of the problems.
Exactly. And a lot of the woo-woo out there says, oh, we've cured your kidney disease with this, whatever the long list of nonsense that we just discussed. But what happens is when you get sick, whether you get fever, whether you have diarrhea, whether you have vomiting, whether your blood pressure goes down, these are common things. You can go from a common stage 3 patient to a stage 4 or even a stage 5, like James did.
Yep.
That happened to James. It was in the hospital. And these are short term for most of you. And they can be corrected easily by your doctor, by giving you fluids if you're dehydrated, by getting your blood pressure back up if your blood pressure dropped, or getting you off blood pressure medicine for a while. Possibly, if you're bleeding, giving you a blood transfusion. One of the commonest situations is you're on a drug, like you're taking a bunch of NSAIDs, which is stuff like Motrin, Aleve, all that stuff. And those things, you get sick, you got a fever, you're taking all that stuff, you get dehydrated, you've already got CKD. It could easily drop your GFR from CKD to CKD 4 or 5, from a 3 to a 4 or even a 5. Very, very common. Get you off those things, give you fluids, back to your baseline. And even ACEs and ARBs sometimes can do it when you're sick. So those drugs can also give you a decline of kidney function. Stop them for a while, it'll get better. One of the most common reasons that people start dialysis, especially if you're an older person, you go in the hospital, you're sick, you already got a weak heart, your heart got a little bit weaker, your kidney function will go down, not because the kidneys got worse, because your heart got a little worse. Get that heart working stronger, your docs get in there and get your heart working better, your kidneys will work better. Too many people go in the hospital, got a little bit of heart failure, doc says, oh, now, madam, sir, your CKD 5, which is what, James? What level of GFR?
That would be below 15.
Yeah. So they're saying, oh, your GFR went down to 12. We're going to put you on the machine. Don't rush. Say, hey, doc, let's see if we can see if my kidneys are recovering. My heart failure may get better. My dehydration may get better. I'm going to get off the drugs that cause the problem. Let's see if we can wait and see if these kidneys are recovering. Unfortunately, because of the business of medicine, I hate to say that, but you put people on a machine, you're going to get reimbursed at a very high level, and for most situations, the docs don't look back. So be careful and ask if there's a possibility that your kidneys can recover. So, all right, James, we're going to answer some questions, and I'll let you pick one.
We got lots of, and hold on, there is one. You're going to love it.
Go ahead.
Because it's got such a positive answer. Hold on. Oh, where was it? Okay, here we go. Oh, here we go. Carolyn Barr. Hey, Carolyn. Her eGFR is 56. No protein in the urine. Yay! She's asking, does she have a big problem? She's 80 years old.
Thank you, Carolyn. You are a great, great example. Okay. Now, it would be good to know how many tests you've got, but I would say if that's a 56, I would not call you a CKD patient. I would certainly repeat it. I would certainly, maybe check it once a year. But as we said, because of your age, it's expected that your GFR will be, on average, at your age, probably around 55 to 60. That's probably normal for your age. So I would say it needs to be followed. Your urine protein needs to be followed. but it's not something that you need to be treating. You certainly should, if you've got high blood pressure, have that treated. But I would say not to worry. Don't let your kidney doctor or your GP worry you about it, but it deserves to be followed like any other lab test.
I'm so glad she doesn't have protein in the urine. All right, here's one, and I have an idea, a guess for their answer. We'll see what the professional says. Truth Win says I have stage 4. Yesterday they peed a little bit of blood and it was painful. Oh, I remember once that happened to me. After the amount of pee has reduced to probably a quarter of what it used to be. What might it be?
Hmm. Okay, so I mean the stage 4 and a little blood and pain is not something related to your kidney function. It may relate to something in your bladder. It may relate to possibly passing kidney stones, especially with blood. So, blood and pain are often signals of kidney stone. And the usual recommendation is to strain your urine. And I know it's not the most pleasant thing, but you should collect your urine and put it through a cloth and see if there's any kind of gravel or stuff in it. That's the quickest way to determine if you're passing stuff. And you could also have stuff in your bladder itself. There are bladder calculi, and they could be in the kidneys, and they could cause pain when they pass. And this is a male or female? I missed it. It was?
Trust Winds. I cannot tell because the picture
Okay.
is from an
Okay.
airplane.
Yeah. So in men, you've also got the prostate that can be causing pain and blood in the urine. Females obviously don't have to worry about that, but it could be in a male a prostate issue, a kidney stone issue, a bladder issue. It's a urologic problem more than a nephrologic. So I am a nephrologic doctor, a kidney specialist. We're the ones who deal with kidney function, dialysis, and various types of kidney diseases. The urologists, I hate to use this term, but they're the plumber. They're the people if you got blockage of your kidney or you got passing blood because you got a problem with something going on in your bladder or kidney stones, they're more often involved with that kind of problem.
Yeah, that's definitely something I would tell my primary care physician so that they could look into it. It does remind me of when I had um, a kidney stone and it passed. I did not have to have anything done, but it was painful.
Yeah.
Um, Now here's what I don't know how to pronounce the first name. Last name looks like Abby. 43 years old with the eGFR 62. Doctor says he or she is okay, but they have a 2 centimeter cyst on their kidneys. Any concerns there? They're asking, what should they be doing?
Okay, so a 43-year-old with a GFR of 62, that is certainly, as we said earlier, age adjusted eGFR should be more in the 70 range. So that could be CKD. We need to know your protein. Got to put it up again. And
Yep.
then you've got a father I assume your father is, at least in the 60s, but 35, you both have
Mm.
eGFRs that would qualify as being called CKD. But again, the most important thing, as we discussed tonight, to figure out where you're at and where you're going to go with your kidney problem is to know how much protein you have in the urine. You also need to know what other diagnoses you have. Do you have high blood pressure, which needs to be treated? One of the most important things to keep you from going into kidney failure is to keep that blood pressure in a good range because high blood pressure can cause kidney function decline. And if you're a young person with diabetes, especially controlling diabetes. So you need to know protein in the urine and what are the causes of your kidney problem for yourself and your dad. but you both, I would say, by GFR, have CKD.
Now, here's one, and this person probably asked the question before we touched on this, but just to reemphasize it, because this is something we always get asked every single show. SW tells us, hey, here's my creatinine. What can I do to get that down? They're trying to lower their creatinine.
Okay, so the Jardiance is, which one is that? That's the SGLT2
Yeah.
and losartan. Okay, so again, anyone who watches your show, James, should not only give us your creatinine, but we need to know, if you have it, your estimated GFR and your urine protein. Okay, and you your creatinine, and let James answer this one for you. Go ahead, James.
But creatinine is not the thing to chase. I know it looks like it because it's on those lab tests. And you're like, oh, if I just got rid of that, my problem would be gone. It is just something used to estimate your kidney function. So don't focus on creatinine. I say focus on living a heart healthy life because CKD is a risk factor of heart disease. Stay active, like Dr. Rose said, stop smoking, don't do the things that are bad for you. Eat a healthy diet and focus on any symptoms that you may eventually develop so that you can manage those.
Now, I don't know why your doctor put you on losartan, which is an ARB, and the SGLT2 drug, the Jardiance. Those are good drugs. You hadn't said if you're diabetic. Don't focus on the creatinine, as James said. That's not something to think about. You need to know how much protein in your urine, especially if you do have a good bit of protein in the urine, especially if you are diabetic. Those two drugs are the right things for you to be on. So uh, your doctor should measure your estimated GFR, glomerular filtration rate, and your urine protein, your albumin creatinine ratio, and you should not look at anything that says I'm going to lower your creatinine. That's not anything that's going to benefit your kidney function. Some people say, let me drink a lot of water to dilute the creatinine. Nonsense. It's just a marker that they use to establish how your kidneys are doing. Don't try to get it down by some ridiculous way.
All right, I'm trying to scroll through and find other questions. There was one in here somewhere. I haven't found it yet, but I remember the person mentioned their eGFR. It was kind of high. I think it was in the 70s. Um, and they were wondering if a whole food plant based diet could fix or improve things for them.
Don't fall for any of these things that says your diet is going to cure your kidneys. It's nonsense. You're on a healthy diet to prevent the things that, if you have CKD, are giving you a risk of getting, like a heart attack or a stroke or congestive heart failure. So you're on the plant-based diet. It's a heart healthy diet. It's not going to cure kidney disease. There's no diet that cures kidney disease. There's no supplements. There's no probiotics, no herbs. These things, as a matter of fact, the National Kidney Foundation urges you against taking any of these herbal things. Okay?
Mhm.
Diet's fine. Plant-based diet is fine. And you probably don't have CKD with a GFR of 70, especially if you're over 65, as we discussed earlier. So you're not um, not emphasizing the right thing.
Yeah, very good. We got to take care of our heart. That's what we got to do. Focus on being heart healthy. Sonia, who's a regular here, asked, can you get rid of the protein in your urine through, or are there ways to do it without medication?
Yeah, as we said, very low levels of urine protein are going to fluctuate a lot. If you've got significant protein in the urine, as we talked about, over 20 outside the U.S., over 200 in the U.S., the albumin and the creatinine. Yeah, in that situation, uh, that's real protein, and you need to do the things we talked about: the ACE, the ARB, the SGLT2, um, and um, and possibly a GLP-1. Um, I'm going to start from the bottom up here,
Yep.
James. Someone say Jay's asking about empagliflozin, Jardiance. It's a great drug if you've got significant protein in the urine, and it's a great drug, as we said, to give you a better chance of living longer in terms of heart problems, and it may also, it's been shown to slow your decline of kidney function if you with that if you've got protein, significant protein in the urine. Um, Lytton says 37, stage 3, GFR 57, diabetic, and high blood pressure.
Mm.
You can eat anything you like. Any eggs and chicken are a good protein source. I mean, I don't have a problem with that. You can try to eat a plant-based diet. And, you know, one thing that comes up with diabetics is the people that are pushing these very low protein diets,
Ooh.
please stay away from them, especially if you're an older person. It can give you decrease in your muscles. It can result in you falling because your muscles will get weaker if you don't get enough protein. Your muscles need protein. You can get bone fractures, fractured hips. Stay away from the very low protein. And especially with diabetics, if you're trying to be on low protein and you're on low carbs, you know, what do you got left? It's not much. So
Yep.
it doesn't make any sense. You can be on a moderate protein restriction, and I think chicken and eggs are fine. They're great protein sources. Um, Somebody's talking about taking the prophet, taking potassium for CKD3. Potassium is not a treatment for blood pressure, and don't get confused about that. Although there is potentially benefits, but it's not used to treat blood pressure. So I don't know where you're coming up with that idea. What can happen with a lot of people on blood pressure treatment is that they need potassium. For what reason, James? What happens to a lot of people?
Oops, sorry. I was going through and looking for more questions.
People with high blood pressure that get treated and they get a low potassium. Why do they often get a low potassium, and they may need potassium?
Is it because of uh the one that gets rid of water?
Yeah,
Yes,
diuretics.
diuretic.
Diuretics get you to lose potassium. So you may be confusing the fact that your doctor's giving you potassium with your blood pressure medicine, especially on a diuretic, if your potassium tends to be a little bit low. Here's somebody who's 66, non-diabetic, GFR of 22. Blood pressure is 100 over 60. Had severe anemia, got a bunch of, this sounds like a lot here.
And
Okay,
gout. Yeah.
yeah. Well, my main thing is to not allow your blood pressure to get too low. So around 100, your kidneys may not be happy. So I don't know what other medicines you're on, but getting your blood pressure in that range may be not so good for your kidneys. And and if you're having that low blood pressure because you got a weak heart, then the empagliflozin, the SGLT2, is great for the heart issue. Okay. Um, you want to pick another one, James? We got a few more minutes.
Let's see. We just had one come in from Ruben. FSGS is on losartan, dapagliflozin,
Okay.
another
Well,
one. I'm bad at
okay.
pronouncing these
Well.
names.
Okay. So Ruben, okay.
Ooh.
So you have one of the unusual kidney issues where you get a kidney biopsy. What happens if you have a lot of protein in the urine? Your doc will figure out why that is, and they often do a kidney biopsy. And your biopsy showed you that diagnosis. And my guess is what you're saying is you still got a lot of protein in the urine, and you are on a great regimen. you're on an ARB, losartan. You're on the dapagliflozin, the SGLT2, and you're on the finerenone, and if you can get it and you can afford it, that all those things may benefit that high protein in the urine. And what's been shown, if you can decrease the high protein, you can slow decline of your kidney function. So I'm glad to see your kidney function stable. It looks like they're doing the right thing. Don't feel hopeless. Your docs are doing the right thing. The only other thing that may potentially have a benefit is the GLP-1, and I'm not sure you need it. I think you're on a good regimen, and your doctor's doing good by you.
Yeah, there was one here where a person's asking, they've heard kind of a rumor that statins may damage your kidneys. Is that true?
Not. No, no, no. But what can do it is the drugs that you take for stomachs, the Nexium, the Prilosec, it's called proton pump inhibitors. Uh, they should only be used short term. So things that can mess with your kidneys are your NSAIDs. Now, the drugs, let me just make one pitch. You only got 3 minutes.
Yep.
If you are one of these people with high protein in the urine, it is not uncommon that if you get on an ACE or an ARB, or you get on an SGLT2, or you get on a GLP-1, you may get some decline initially in your kidney function, but you may still have a long-term benefit to slow the decline. It's been shown that too many people, their doctors get scared when they start one of these drugs. They see some small decline of kidney function and they stop them. And it turns out studies show that you're worse off by doing that. So just a little bit of a plug on something that's very common.
Now, Hummingbird just asked a question related to that. His or her GFR is 16, and their doc said it's too low for an SGLT2. Is that sound like that is too low, or is he just
Well,
worried about
it's
the
not,
drop?
it is currently off label, meaning that the FDA is not giving the green light. But I will tell you this. I mean, I keep getting more, and I stay on top of the research studies. There are more and more studies that are showing the benefits of that SGLT2, not just for the urine protein, not just for your diabetes, but for your longevity, to decrease your risk of having a potential heart attack or getting heart failure. So it would be off label and it's not FDA approved, but I see what they're concerned
Yeah,
about using.
let's get one more in here, and this is one we rarely ever get asked, but I see it a
Yeah,
lot in emails.
yeah,
What
yeah.
is your opinion on stem cell therapy for CKD?
Absolutely. Woo woo, woo woo, woo woo. We're gonna give the woo woo alert.
I'm gonna have to
Listen.
make one.
I will tell you, folks, that with a lot more work on my part, that I'm going to have a book out that's going to be talking about some of the longevity things of the future. Stem cells have great potential in the future. Nothing out there yet for kidneys. We're not there yet, but there's got great promise. And stay tuned. That's what I'll tell you.
Perfect. And I want to mention, we're at the top of our hour. I want to mention your book again. As you guys have seen, Dr. Rosansky is easy to understand. He's telling you right up front, here's what you need to focus on. Here's what you don't need to worry about. And having kidney disease, especially when you're first diagnosed, there's a lot of stuff we're worried about. We're chasing creatinine, which isn't the right thing to be chasing. So if you don't have a copy of his book, I encourage you. They've got it at Amazon. They've got it at any mom and pop bookstore. They can order a copy of Learn the Facts About Kidney Disease. And to make it really easy, I'm going to bring Dr. Rowe on the screen all by himself. We've got this little QR code you can scan that'll take you directly to Amazon, where you could get a copy of his book. And we are out of time for tonight, but maybe Dr. Rowe, next time, maybe we can talk a little bit about, let me get these things. People are mentioning how great your book is. Maybe next time we could do a little bit of talking about all that success that they've had with these pig kidney transplants. I'm extremely excited about that, and I would like to get your thoughts on that too. Maybe that's something we can fit in next
Yeah.
month when you're
Okay.
here.
All right.
I'm hoping that's the future for me.
Okay.
Get me a
Possibly.
bioengineered one that I don't have to take. You know, those immunosuppressants are not as many of them. Oh, that's what I'm hoping for. All right, everybody. This is the last scheduled recording for the month. I am going to do a hangout this weekend, probably on either Saturday or Monday, which is Martin Luther King Day. I'll be going on here. I'll just turn on the camera. Not sure what time. I'll try to give a little bit of heads up on Facebook and just hang out so you guys can hop on. We can sit there. We can chat. I can answer questions about my own personal experiences and things like that. That'll be coming up this weekend. And Dr. Rowe is here every single month, along with Jen Hernandez, a renal dietitian. This is a great place to get lots of great information that is positive, supportive, and accurate. No woo woo. All right. Thank you very much, Doc. I'll see you next time. Bye, everyone.